superior patient-only care. It's a responsibility that we at Colgate cherish the most. And for that, dental healthcare is an ever-evolving field. And with introduction of new technologies and techniques, it is always essential to stay updated and informed. And today's session is aimed at providing insights, exchanging ideas, and learning about the latest developments and advancements in the field of dentistry, while having a patient-centric approach and ensuring positive patient outcomes. I would like to introduce today's speaker, Dr. S. Mahantesh. He is an associate professor in the Department of Periodontics at the Faculty of Dental Sciences, Ramaya University of Applied Sciences, Bengaluru. He is a periodontist, implantologist, and a laser specialist with more than 16 years of teaching experience and over 10 years of active research in dentistry. Dr. Mahantesh has delivered numerous national and international guest lectures, particularly in the field of implant dentistry, soft tissue management, and dental lasers. He has received several academic awards, research grants, patents, and scientific publications in reputed journals. He is a fellow of the Pierre Fortune Academy and the International Congress of Oral Implantologists, and an associate fellow of the Asian Academy of Laser Therapy. So today he is going to share his insights on beyond osseointegration, the art of soft tissue management. So with this, I would like to invite Dr. Shashikant to felicitate the doctor to start the lecture.
I'm so happy to be here. I'm waiting for you guys from past 4 hours in fact. From 4:30 I'm waiting when it becomes 7 o'clock. Then they told sir, here the program starts after 8:30. Then I was waiting, no problem. Because all the way I came here, I had to finish it and go. That is my motto. The most important thing is, Mr. Basuraj approached me. Sir, give a lecture with Colgate. This is the first time I'm going with, the oral maintenance, the group and all these things. I usually associate with the By Horizons. That is my favorite brand and I why I agreed this is he told Hubli and down here. I told we'll go to the down here. There was a reason behind it. There's an emotional attachment. In 2019, from Idea people only invited me to give a lecture and answer on lasers in cards. That was my first lecture. From then till now, I not stopped giving any guest lectures. Nationally as well as internationally. In fact, the last November I was in Germany. They invited me, one of the best university, that is Freiburg University, to conduct courses and deliver lectures on my favorite topic is in soft tissue augmentations. I was so taken back and I was so happy to be back to down here. It's all because of that emotional attachment. I'm not from Bangalore. I'm basically from North Karnataka only, from near Pusti, that is Tavaria only. So I'm not from Bangalore. Bangalore just because I went to study, then I married to a Bangalorean girl. Forcefully I stayed in Bangalore. I'm enjoying Bangalore. That is a different story now. That is because of Bangalore. In fact, so many advantages I got it. That is what I'm enjoying in my life. Fine. The most important thing, I don't know whether how many people are practicing implants in this room, but everybody wants to know about the implants. That's most important. So when we are doing the PCs, when I'm doing my implants, then my boss used to tell, see the bone, put the implant. That's what we learned. We have to assess the bone by, that time there was no CBCT. First just we go for the OPC, take scale, measure it vertically. And where is the canal? Just keep little away from the canal. That is the length of implant, place an implant in that area. That's what we learned. That later, there are so many things are associated with that. I'll come into factor. This is where I studied and where I'm working. That is my university, that's Ram University, where it's given bread and butter. It's given the life as well as the wife, both. I got married my senior itself, he was my senior, he is also periodontist. So I always be in Ramaya's name only because it's given both thing. This is my practice. I'm sorry if I not come to that side. This is my practice. This is a small practice. This was my small practice. Now I open one more. I don't know how many of you are interested to know about the soft tissues now. After my lecture, definitely you will have an eyes. If you are calling a consultant as an implantologist, then you think about, see sir, think about soft tissue now. Don't think just only as integration. Because so many factors involved in that. How many of you see, by seeing this X-ray, what you can expect? What you can say that? What you can see in this X-ray? Implants are properly placed. There's not much anything each other, and it's away from the sinus, fine, and it's also integrated, excellent. So according to dentist, this from there, that is where my journey started. I'll just take you about a small story. How I told, don't touch this patient. Don't load now. We'll load after the something will do about soft tissue augmentation, and will think about it. But he told, no, I have to load it because patient is not eating food almost for 6 months. If I say one more surgery means he will not allow us to do anything, I load it. After the loading, I'll tell you what exactly happens in the future slides. And one of my friend referred, can you do something for this? So always we try to replicate the soft tissues by using the composite or ceramics. We cannot. So in this case, ideally speaking, there is no need to put implant so labeling, and no need to put cover with pink composite, and no need to put one tilak also in that is screw retained, that in the aesthetic zone. So these are all the problems with initial itself. If you plan properly in aesthetic zone, that's why the patient, whenever he goes in front of the mirror, they'll follow up and say that my tooth is exposed, my implant is exposed, it's not looking great. All these things every day. That's what we always assess. We'll see only once the CPC will place an implant, but patient will always keep watching your outcome of the treatment in the mirror every time, 3 times a day at least. So to avoid those kind of complications, you need to plan it properly before itself. Can you see this case? They call me and say, or they'll send me. Because he didn't know about the soft tissue issue in the implant dentistry. Always, wherever you go, in international, national, the issue in the implant dentistry is a soft tissue, not a bone issue. Issue in the implant dentistry is a soft tissue. You can place implant wherever you want, whereas there is a bone. But getting a soft tissue, there is a big challenge. That's the most important. See this patient, they referred me, let's do something for this. Once I open a flap, all the implants are they're hanging out. What you can do is, you can't do anything there other than you have to pull it out. See, I'm not a magician. You can't do anything. No, there is a limitations for everything. Right? So there are indications, there are contraindications, there are limitations for each and every procedure. So why I'm telling all these things, why I'm showing all these cases, when you plan for an implant, keep it in mind about the soft tissue also, not only the bone. See this case. It's a beautiful root removal partial denture supported with implant. Because they could not do anything for this, patient is keep going back to them and saying do something, so do something. So just they're given an RPD and send them back. which they would have done nice repair for this, which was the fault of the dentist. It's not fault of the patient. Patient always comes to us for the teeth, not for the implant. The implant is one of the means to give you the teeth. They are not asking for that. They want beautiful teeth, beautiful smile, and it should be functional. So that's the reason when you plan for that, plan properly. See, what best I can do in this case? I can't do anything for that. So many threads are exposed, and the implant is positioned too labily, and there is no bone at all inside. See the X-ray of that, where it is. I can't do anything for this. The treatment plan is just remove the implant, go for the vertical bone augmentation, recontour the nice bone, get the beautiful keratinous tissue around that, then you can go for the implant. It's a case of the full mouth rehabilitation. It's a different story. I was just going through some articles. Nowadays the courses are right and left. 6 days, 6 implants, 3 days, 3 implants, 4 days, 4 implants. There's a course is now the trend. Okay? If you do in 6 months, 6 days, you can't do the implant in 6 months also. But if you do this 6 days, how can you place 6 implants? 70% of implants already placed in the world, they need GBR, they need keratinous tissue augmentation now. That is very important now. They are all ailing and failing implants. This is what the literature says. Why this is happening? Because of lack of knowledge, lack of training. Then what will train is assess the bone, put an implant. But there is less chance, less people are teaching about the soft tissues. Because as a periodontist, I should educate the people that yes, soft tissue also big issue in the implant dentistry. Not today, but tomorrow definitely it will come on the shoulder. Every time patient. That's what the small story, what I wanted to tell you that. Initial days we used to just assess the bone, put an implant and send the patient. But after 3-4 months, patient is to come back. Say that my implant is coming out. How it will come out? Yes, because the gingiva is going up. The threads are getting exposed. The color has become black. That's why patient is coming telling my implants are coming out. So this is not easy to solve the problem. Just augmentation of the implant is very difficult job because there is a lot of anatomical structures, histological issues in there that we are going to discuss later about that. Coming back to the next, these are about 20 years follow-up the studies. So nowadays, initial days we used to say the 5 years implant comes means it's a success, fine. 10 years means it's a great success. Now we have a lot of literature. Recently in 2025, there is a Frankfurt University people that published around 25 years follow-up the cases. They've proven that wherever there is a keratinous tissue, they could get a very good result. Wherever there is lack of the keratinous tissues, there is a chances of failure of implants. This is what the study says that. About 20 years follow-up. Yes, bone was issued, but soft tissue is most important. The soft tissue is not only for aesthetic, there is a lot of functions around that. What are the functions we are going to discuss in detail about the soft tissues. So I always say is that this is what? If there is lack of the keratinous tissue or the implant, it end up with peri-implantitis, biofilm accumulation, soft tissue inflammation, mucosal resistance, so many things associated with that because of lack of the peri-implant keratinous mucosa. So you should always assess along with hard tissue, soft tissue is most important. That's why I always put this slide. It's a small tissue, but big issue. When I joined Perio, people used to laugh at me, 2 mm, why you want to read so much? Just for 2 mm of gingiva, why you want to read so much? That 2 mm gingiva now giving me bread and butter. That 2 mm of gingiva making me famous. That 2 mm of gingiva giving me so much of what I wanted. Because it's very difficult to handle the 2 mm than 20 mm. Easy to handle the 20 mm of bone, but very difficult to handle the 2 mm of gingiva. Okay, so you should know about how to handle the soft tissue. See, now there is so many implants. You name the companies. Every implant is getting polished. Every implant is getting, the upgradation happening. So many things are happening. Anything is happening in relation to the soft tissues? Nothing. It's all your own skill. This implant is not possible, put to Chakamotic. That is implant is not put to glabella. This implant is not possible, go for bicortical. This implant is not at all possible, there is no bone. Go for the specific, patient specific implant. But what about the gingiva? No one talks about that. Issue is there because there is no modifications. This is only skill based, the only knowledge based. Any implants body will accept. Any implants body will accept. Only things you have to engage into the native bone, it will accept. But management of soft tissue is your challenge, your smartness. So the soft tissue management starts from the diagnosis itself. It's not after placing implant. I have a beautiful article which is published in period 2000, when to start, when to do it. So it starts from the diagnosis, planning, surgical planning, prosthetics as well as the long-term maintenance. What is the diagnosis, sir? When the patient comes to you, you always see the quality of the bone, quantity of bone, that's fine. Along with it, you assess the quality and quantity of the soft tissue also. How much is the keratinized tissue? Yes, good amount of bone is there. When there is no keratinized tissue, if I place the implant, not today, after 2 years, patient will come back to you. The patient mentality in India is, once I paid, they are my workers. Every time they keep coming back to you. Doctors are 30,000 a year. Throughout life, we are free treatment they expect. This is what the Indian mental. That's why if you don't want to keep repeating the same thing and patient, don't do that kind of cases. That's what I was discussing. We can charge the patient for full mouth 4 lakhs. We can charge the patient for the full mouth 10 lakhs also. The person is paid 4 lakhs is for him. He thinks that he is paid 40 lakhs to you. Because that is his capacity. That is his top level. So each implant, full mouth rehabilitation especially, we always advise go for this water floss. I'll always give number, Basuraj number, call him, you'll give the best price, doctor's price, please ask them to get it. He'll keep sending to them. It's a beautiful, because we have done the comparative studies with Oracure, so many companies are in the market. But this gives the good result because you can adjust the pressure, you can adjust the water pump and everything is in that. So this is my favorite equipment after the implant placement. So just going back one small case. She herself is a gynecologist. She had visited and she told that some issues happening with my tooth. Can you see this? There is a small crack in the premolar area. Why I am showing you this case is how you start the diagnosis initially itself for the prognosis. Okay. So if you see this, first we'll assess the tooth, there is a crack. That's next thing I always assess what is the amount of the keratinized tissue left around that tooth. Because that is my future tooth. That is my future gingiva. Then I'll assess implant. Where can I place implant? Once you remove the keratinized tissue is there. There is a width of the keratinized tissue, length of the keratinized tissue, thickness of the keratinized tissue. Where you can place the implant? There are two routes. Definitely there is as such. Whether shall I go in the parietal area, shall I go in the buccal area, or shall I go straight? The planning starts from ear itself. This is a small video. From ear to ear. If you see, I didn't lose any single of the gingiva here. Because see, the pre and post, the quality of the gingiva is maintained, the quantity of gingiva is maintained, and see about internal papilla is maintained. This is started from the planning itself. where to place an implant, how to place an implant, how distance. See, if you go back and see, the implant was almost 4 mm coronal to the gingival margin, internal papilla basically. So that is what your placement of implant should be there. No need to engage the threads. Don't think about counting how many threads I'm going to engage. Short implant, long implant doesn't matter. Long implant is where you have to plan. When you want to engage the bicortical, there only the length matters. Otherwise, length doesn't matter in implant. According to Colgate says that the occlusal forces, the compressive forces can, go up to 6 mm of the diameter of the implant. That's it, only 6 mm. Only 6 threads are getting more occlusal forces than apical forces. If you're planning for any bicortical engagement, then only the length matters. Otherwise, it doesn't. See, this is what the beautiful, this got this place, the EBC zone, that is subclinical counter, critical counter, what is zone E, what is zone B, that's what everything got it. The success rate is 100% here. We are not going to lose any kind of the papilla at all. And the quality of the gingiva also, it will never compromise in that. So this, why I'm getting this case is because the planning itself is a matters. If I would have taken out the tooth, put a bone graft and sent them back, I could not get those zones. I need to preserve that zones. For that, we will go for the imminent implant. This is what the so many articles exist about the soft tissue augmentations, lack of keratinosis because leads to peri-implant. So it already shows long-term success with the 20-year follow-up, all the cases. Those are followed up 20 years also. Those cases had more than 2 mm of keratinized tissue, the success rate is more than 95%. The less than 2 mm of keratinized tissue, success rate is less than 65 to 70%. That's what the study says that. You should, when you are thinking, place an implant, you always think about, there are two routes. One is a man-made route, one is a God-made route. See how the soft tissue play, different in these two surfaces. Here we are creating the more ridges. Here we are creating the more roughness. We are creating the more porosities just to increase the surface area for the better osseointegration. But the God-made route is almost, the most of just little roughness compared to this. If you see, the depth of surface is 5 to 200 micron on the implant, and the tooth surface is 70 to 20 microns root surface. If you see this roughness, how the tissue will act, how the tissue will react, it's a different way. That's why when you're planning for the soft tissue augmentation, you have to think about this also, where I am putting the soft tissues. If you see this, the histological differences between the tooth and implant, this always keep it in mind about that. Here there is a good amount of periodontal ligament, and this is a rich source for the blood supply, and there is a lot of cells along with that. But if you see for implant, there is no periodontal ligament space also. There is no progenitor cells, there is no stem cells, there is no vascularity. The only bone associated with the implant, and arrangement of the fibers also different. Around the implant, the gingival attachment is very weak because the fibers are parallel to the implant. But if you see the tooth structure, it is perpendicular as well as a parallel. So that makes the more seal compared to the implant. So implant seal is always weak if you compare to the histology. Why I am showing this is, see what will happen if one thread gets exposed. If the root gets exposed, what will happen? Patient will complain about little bit of sensitivity, then you advise the desensitizing toothpaste, it will be half of the problem solved. But if one thread gets exposed, it leads multiple problems. This is what the study says, that what if the threads get exposed, what all the microbes will get accumulated. If the root gets exposed, what all the microbes get accumulated. So definitely this is it's more dangerous and as well as more difficult to clean it up compared to the root surface. That is the different concept. Why I put that is, one thread exposure is equal to almost 4 times prone for the peri-implantitis. That's the reason you keep the implant inside the bone, keep the implant inside the soft tissues, keep the implant surrounded with the thick quality of the keratinized tissue. Because even one thread exposure also leads to so many folds of peri-implantitis. What will happen if the thread gets exposed? because whatever the components, see, because of the thread exposure, it acts, it releases the titanium particles. This cell stimulates all the cells, fibroblast, osteoblast, all these things. That leads to perimplantitis. This is my core area. I got lot of research and fund from the ICMR. I published it also. Lot of work is I'm doing on this about the perimplantitis, titanium leach. There are lots of articles published on animal studies. Now I'm publishing the human studies. The perimplantitis related to the exposure of the implants, and this is like egg and chicken story. Whether perimplantitis leaching the titanium particles or titanium particles causing the perimplantitis. These all studies are going on. These are all animal studies. These are all my, initially I taken from that. Then I started my own studies. These are all around 5 studies I published, all about the titanium leach. In fact, I removed the implant, did the selectioning, and do the histology assessment also. This is the second set conclusion. This is the third study. This is the fourth study. So we compared all the type of implants along with that. We compared the what kind of implants, how all these things. Multiple studies are published. In fact, if you go back to Google and ask the normal titanium level in implants, means my article comes first, because it is first article to publish it about the titanium leak in the human serum after the perimplantitis. So first thing is that how do you identify it? Whether it is the keratinous tissue is enough or not enough, whether it is thick or thin. It's a simple meaning. That's about visual examination, and you can use the probe and you can use the reamers to assess the thickness. Whether it's a thin diport or thick biotef. If it is more than 1.5 mm, it's the best, you are in the safer zone. If it is less than that, you are not in safer zone, you are in the danger zone. Coming back to the case, that's beautiful. This is what the Lindqvist case is famous for the zero bone loss concept. He's famous in that he conducts a couple of courses everywhere worldwide. So he always says that if it is a thin periimplant tissues, thick periimplant soft tissues, if it's a thin periimplant soft tissues, more amount of crestal bone loss compared to the thick kind of the periimplant tissues. That's it. This is what is more concerned. Now, when to and how to improve the periimplant tissues. This is what is different. There are so many. You can use free ginger graft to increase the keratinous tissue. You can use the connective tissue graft to increase the volume of the tissues. Or if you don't want free ginger graft and connective tissue graft, you can use substitute graft. So these substitute grafts, there was a first study, in fact, I conducted, I got the direct sanction from the buyers and from the USA. There's the first study in India. We had done a lot of research on the substitute of the connective tissues. Those studies are also shown in the next slides. So this is a beautiful article published in period 2022 itself, when to augment. This is a chapter. You can't augment the gingiva. It's best when you want to augment. If you want volume and as well as the attached gingiva before implantation is the best. It's a minimum risk of complications. And if you do the connective tissue, when you place an implant, it's a moderate risk. So that's what, wherever there's a green, it's a good result. Wherever there is a yellow, it is moderate result. When you want to augment the tissues after giving the crown, you are in the risk phase. The success rate is very less. So this is a chart, it's proven that when to augment your soft tissues. This is just one case, his poor guy is, he's an engineering student. He met with an accident and he's lost his teeth. And he admitted in JC and college. They had done all the possible the management aspects. In fact, they had taken the graft on the other part, then he placed it in black graft and everything, and graft got exposed. And you can see the bone loss is almost like arc-like. Now at the end, he has come back to me to do something for this. Remove whatever the necrosed bone. this case, sorry, he came back to me. You can see there is a necrosed bone and as well as there is hyperplastic gingiva in that area. It's not a normal part of the gingiva. It is all just because of irritation. There is kind of irritation fibrome. So I am using that fibrome as for my gingival graft. I'm not taking it anything from the palate. So I'm just taken out completely whatever that is excess part of the tissue and just split it into the pieces and suture it back. And if you see that I've just taken the palatal, it's giving the nice vestibular incision, has taken the tissues apically, and we can use another substitute that is mucograft to cover that area. This is after 2 weeks of healing. You can see autograft healed much better than the genograft in the same patient. This is after 2 months of healing. This is what the pre-operative, this is what the peri-operative. You can see the amount of the keratinous tissue I could achieve this. This is before placement implant. Because of that, I could do the beautiful implants in this case. The later go for the implant placement, place the implant. This is the lower side, place an implant in the lower teeth also. And if you see here, there is exposure of the implant as well as there is no keratinous tissue, there is no vestibular depth at all. In the same patient cases, upper and as well as lower. Then take the tissues from the palate. Usually say they don't take it from the erogenous area, but I love that area. And in this case, they attempted full palate. Nothing was left. They done 3-4 times already the soft tissue augmentation. The only tissue left is only in this area. In fact, if you see, I had given the incision in the priorly in this area itself when I placed the implant in the upper area. I used the same tissues for the lower teeth. So multiple area in the same area too. Then taken the tissues from the palate and augmented in the vestibule in the lower areas. If you see the quality of the tissues I could get. If you see that initially there is no vestibule depth at all. There is no keratinous tissue at all. Now I could get the good vestibule depth as well as a good keratinous tissue. Only the colors doesn't match. That is the drawback of the free ginger graft. But see the quality of the tissue I got. See around the 3 to 4 mm the implant margins in the crest of the implant from the crest of the gingiva is almost 3 to 4 mm. This is pre, this is a post. And this is the final restorations, both upper as well as the lower. The patient can maintain these areas. And I can expect the good success rate. Is almost 5 years follow-up this patient. And I always, as I told, I'm going to advise these kind of brushes, and as well as this is a favorite, the Colgate Blast for the peri-implant management. This is the another case from Shimoga. In fact, myself only attempted once for the vertical augmentation and got failed. The second time again I went for the same areas for the augmentation. But if I place the implant directly, if you see the ridge of the lower ridge, the crest of the lower jaw is almost lower than the floor of the mouth. If I place the implant and there is no keratinous tissue at all, and when there is no vestibule depth in keratinous tissue, if I place the implant, it will become vertical cantilever. I cannot do that implants in this case because he is just a 20 to 24-year-old boy. I want the long-term success. In these cases, first I need to augment the hard tissues. Okay, we plan for the hard tissue augmentations. Is what the width and height of the tissues. Already there is a scar, given the nice incision, reflected full thickness of flap. These are all already attempted cases. Everything we removed it, okay, and go for the vertical augmentations with autograft as well as a genograft combined. Then increase vertical. So here you could see how much the height you could get it. Fine. This was a pre and this is a post. You can see how it's arc-like shape, and now how much I could get the good height of these hard tissues. Then now see about the soft tissues. There is no keratinized tissue at all. Whenever doing the vertical augmentations, you are going to lose the soft tissues. Especially the keratinized tissue, you will not get the keratinized tissues. So there is always inform the patient for the second surgery. You have to go for a soft tissue augmentation also. This is what got it after the 6 months. See the amount of bone you could achieve. This is the amount of bone I can get. This is pre-operative, how it was, and post-operative, how it is. Then the real game starts here about the soft tissue management. I can place the implant right and left and leave it, but it's not possible to maintain for the longer time. So now I need to increase the keratinized tissue width. For that I need to take almost 30 mm length of the soft tissues from the palate, almost from the second molar to the lateral incisor. There was a time I need to get scared. Now I don't get scared. I'll take the full palette of tissues. I'll show some cases about that. Then give the vestibular incision parallel to the periosteum. Don't cut the periosteum. Increase the vestibular depth and place this soft tissue graft beautifully. I don't puncture the soft tissues most of the times. I try to adopt it without puncturing the soft tissues. Then see the result. So now they're ready for the implant placement. I could get the height of the hard tissue also. I could increase the quality and quantity of the soft tissue also. Increase the vestibular depth also. Patient can maintain. Now it's almost, if you see the height and width, it's almost like a normal job. This is after 6 months. Now I place the implants. This is what pre-operative, this was mid-operative, this is a post-operative. Hard tissue augmentation at the end, this is hard and soft tissue combination. You can see the differences both. Then you can place for the implant. Full thickness flap, implant is placed. This is all brain guided, nothing is guided surgeries. If you see how the implant is positioned, immediately put a healing cap. Then still the cases, I need to load it now. I could achieve both hard tissues and soft tissue in the cases. In this kind of cases, patient cannot brush immediately, so you can advise the period is one of the best. There is 0.12% of chlorhexidine, and whatever the most patients who are advising this for the short term, not for the long term, just for the 2 to 3 weeks, so that you can ask the patient to discontinue later. This is chemical plaque control. There are certain cases where you want. So these, what are the cases I showed? There are both cases are before implant placement. I augmented the soft tissues, and you will get the result because less tissue manipulation. But there are certain cases you will do it during implant placement as well as after implant placement also. Sometimes I'll play a game. Most of the times, what you learn is you have to take the gingiva. You want to go for the free ginger graft. There's only site is the palate. But I use the palate, I use the tuberosity area, and I use the crest of the ridge also. So in this case, if you see there is a deficit, there is no vestibular depth, there is lack of the keratinized tissue, as well as the height is also less in this case. So our patient is not willing for take the tissue from the palate. The only left option for me is the same area. Already there is a deficient. Why you want to take it? I'll just show that. Fine? Okay. The layer by layer, just detach the fibers and increase the vestibular depth. And I'll take the tissue from there itself. The soft tissue graft from the ridge itself. Partial thickness, don't expose the bone, don't cut the periosteum. Wow. If you see this, I didn't trim the height of the buccal side as well as the lingual side. I just kept those margins like that only. I taken the tissues in between that, so that again I can expect the tissue grow in that area. Then the tissue was a little less. I give some viscous incisions to stretch that tissue. That's called as accordion technique. same tissue, I'll just suture it in the vestibule area. This is to increase the keratinized tissue. This is to increase the vestibular depth, what it did now. Now the later things, see how beautiful I got the keratinized tissue with it. Thickness as well as the quality also. Now question comes is, here I already taken the implant, the tissue from there. There is again deficient over there. So now I need to increase the volume of the tissues. I need to use the connective tissues. So patient is not willing for the connective tissue. We take the tissue from the palate. Then we used the xenograft. That is what the Noah matrix. This was all sponsored studies, so I could use lot of materials here and there. So almost around 7 lakhs materials, worth of 7 lakhs materials I got it from the USA to do experiment on the human beings. So this is a Noah matrix. It's alternative to the alloderm. Initially used to get nice alloderm. Now it's there because of some reasons it stopped importing. So they have started importing the beautiful Noah matrix. It's a very good matrix. They used it. See the quantity of the tissue you can get it. This is what pre, this is a post. I could increase the height as well as the depth of the tissues by using the free tissue graft as well as the connective tissue graft. Yes, this is case where there is no lack of the keratinized tissues. In fact, the height is there. There is a vestibular depth is there, but only things there is no keratinized tissue at all. Exactly only around 0.5 to 1 mm of keratinized tissue you can expect only in the reach. But here as such there is no keratinized tissue and patient is unable to maintain. How do you assess it is, if you see the ginger inflammation around in the next to the implant, whatever the tooth are there, he is unable to maintain those areas. There ways you need to increase the quality of the tissues. So if you see there is a roll technique to check it. So it's completely immobile tissues. Okay, only you can see about only 1 mm of tissues attached. Then give beautiful horizontal as well as one relieving incision, reflect the partial thickness of the flap, then suture whatever it is, undermine the tissues and suture to the base of the sulcus where you want it. That is your future sulcus depth. Then get the tissue from the palate. Always I split it. Here I am getting the good result and splitting it. So from 10 mm it will become 13 mm, the length. Okay. Then suture it. This is, you can see how beautifully it is adapted nicely. Then this is from occlusal view and just covered with the periodontal pack. This is the post-operative. So I could get the width of the tissues, height of the tissues, and the implants are in safer zone now. Then you can see how beautiful it is, increase the quality of the tissues. You don't see the crowns, they're very bad, but see the quality of the tissues, how much you get it. Now the longitude of the implant successively increase. So now we're coming back to the third phase where you can go for the healing phase implant. See this case. They already placed an implant, already given healing abutment, and if you see the threads are exposed and there is no vestibular depth and there is free nerve pull in this case. So now if you go for directly loading these cases, it's very difficult to maintain those areas. Already the threads are getting exposed and there is no internal papilla also and there is no vestibular depth also. So now to increase the width, definitely you have to think for the free ginger graft. Beautiful partial thickness, reflect it and suture the whatever the edges of the margin, underline it and place the free ginger graft. Okay. So this is, there is a special sutures I am using in the case that is myself only invented and it's patented also. So this suture material is along with the anesthetic suture material, that is. So we are not using much of anesthetic agent or as well as the NSAIDs after the treatment. Most of the sutures, what I invented and what we patented, that sutures I use it. See the post-operative. What beautiful I can. Yes, this is the case what I showed in the first slide. I told him don't load the implant. Implant may get failed or they will get exposed. He told no, patient cannot wait, already waited 6 months, now I had to load the patient. The same patient again came back to me. You see, after loading, you can see the threads are how transparent here. You can see all the implants are almost peeping out. And they are unable to maintain this. Because of that, you can see that is life cycle ginger, what you call it as. Okay, so now what to do about this? I asked him to remove the process. I asked him to remove the processes at least. He is not ready to remove the process because implant may come along with that. He's scared. But now we have to do something for this because all the implants are getting out. So ultimately, this is a challenging case for me also. Yes, we can attempt. This was a pre-operative, what I showed you in the first slide. This is after loading, see how bad it became. It's worsened the condition after loading because of occlusal forces. That's what we are telling. At least after the placement of the implant, if you find that it is not right, augment the ginger there itself. Otherwise, we'll end up in these kind of cases. But still, as a challenge, you are taken. Almost full mouth this is from second molar to the second molar. Patient cannot afford to go for any kind of substitute. You can use mucograft. If patient can afford around 70,000 to 80,000 rupees, he can use it. Patient cannot afford. So only the chance left with us is autograft. And from first, almost second molar to second molar is almost full palate you have to take. You cannot take just 2 mm or 3 mm of ginger. Yes, there is a challenge for us. You can take it from palate to palate, complete, from tuberosity area to another tuberosity area. Just I told patient, you also pray your own God, I also pray my own God, both of us will do together. Because the palate was very thin. Anytime it will rupture and anytime it will start bleeding. But I want a good quality of the tissue and good quantity also because so much of tissue loss has happened in the vestibule area. I need to augment that. See, almost, except this inches of pepper, I taken it almost from the last molar to the last molar. Augment it, suture it. This is the success. This is the most important is how do you suture it? How do you adapt the tissue? Because initial 2 to 3 days is a plasmatic circulation where you should not be having any dead space. How do you adapt is a challenging. See the result. Beautiful keratinized tissues are important. All the implants are masked now. They are sleeping peacefully. Now I can expect, you can think about open the full mouth thickness of flap, then you can think if you want to graft, whatever the choice is yours. But we could get the good amount of the keratinized tissue around that. We could get the good thickness of the keratinized tissue. I could push the mucous junction from the margin to the almost 6 to 7 mm away from the margin. This is what the pre, this is what the during, this is what the post. You can see the follow-up, pre, post. So these all things, when you know how to handle the tissues, there is no issues. That's a more major thing in the implant dentistry. It's fine. These are all about the toothpaste, tooth guard, what we always advise after the periodontal as well as peri-implant treatment. This is a must. You should always advise. I don't advise the floss to maintain the peri-implant health. Recently I was reading one study. The floss itself induces lots of cardiovascular diseases because it pushes the plaque into the circulation. That's what the recent study was published. So don't advise the floss. Advise the internal brush or the water floss is the best thing to do it. So what are the cases we showed? All about the pain, like the free ginger graft, increase the quantity of the tissues. Now we want to increase the quality of the tissues. See this case. Never ever give the hybrid denture in the future. It accommodates lots of the plaque inside. It's almost like a fixed removable denture. Okay, so if you see the implants, how the threads are exposed and there is no quality of the tissue on the implants, while taking out this denture, the implant is out. And quality of the tissue is compromised very badly. And you see that there are so many threads were exposed and they didn't implant a plastic also in that case. They tried all possible things to reduce the plaque accumulation, but they didn't try how to close these windows. The first was the planning was the implant placement. That's the first planning wrong. This was the first thing was wrong in this case. And the second thing, using the multi-unit abutment in a different angle. And third thing is giving them acrylic based denture. So all the steps went wrong. Then definitely we have to increase the quality of the tissues there. So we can use the connective tissue graft. So used de-epithelize that area, whatever the tissues taken from the palate, then de-epithelize it and close it back. That was adaptation of the connective tissue graft. This is a connective tissue graft. How beautifully is adapted, then close the flap. This is what pre, this is what the post. I refer them back to go for the next level of processes. This is a temporary process, still is going on. Then I told her to go for the permanent processes. Then you want to go for the augmentation. See here, the keratinoid tissue is good enough, but only patient is complaining of the foot loss in that area. The bone is in the crestal area, but not in the apical area. There is a lot of space there. So here, no need to increase the keratinoid tissue. Volume is there, but increase the quality of the tissues, increase the volume of the tissues in case. So by means using the connective tissue graft, take the graft from the palate, just de-epithelize this there itself. Sometimes we take completely and de-epithelize here. Sometimes I de-epithelize the patient mouth itself by using aerograft or micrograft. When it starts bleeding, it means you have removed the epithelium. If you take out completely, when you start de-epithelizing that area, it's not uniform. By using these techniques, you will get uniform de-epithelization because you get uniform bleeding spots. Then take out the tissues from the palate completely. Then push the tissues inside. In fact, there was a small video how we do that. Just made the tunnel and push that graft into the tunnel and sutured it, and you see the pre-operative and this is post-operative. Now we need to change these crowns. Patient was not willing to change the crowns, we just left it like that. Ask them to massage the gum nicely, make it uniform thickness. This is after placing the implant. Sometimes this is the case of both horizontal, both hard tissue as well as the soft tissue augmentations. Placing the implants along with hard tissue augmentations. After healing, then we are just tissues and push it back. This one is go back. Suture into the buckle, grab. Cases where you can increase both hard tissue as well as the soft tissues. This is another case. There was Hard tissue deficiency was also there. I don't want to involve that case in this case. We did a resplit technique, then place an implant, then you can see amount of the soft tissues. This is aesthetically unacceptable. So here itself, during the second stage itself, you can manipulate the tissues in such a way that you can create a beautiful emergence profiles as well as create a nice internal trace. For that, you should always give the post palatal incisions. That's called as the Palissy technique. Okay. So now when you place the implant more than 2, very difficult to create the internal papilla. So in that cases, if you incision in the crest, mid crest, you are not going to get any kind of attachment, means soft tissues. So there you have to plan for more palatal incisions, so that the tissue should go in the buccal side from the palatal area. Okay, then place healing abutment, then give the different incisions so that the tissues come in between the implant, means abutments. Okay, and adapt it beautifully and modify your healing abutments. Keep modifying the healing abutments for another 2 to 3 weeks, then you can get beautiful tissue healing. It will increase the quality of the tissues as well as you can create the internal papillas. Initially it was a flat, see how good quantity of the tissues you will get. This is what before the implant placement, resplit an implant, this is what how beautiful quality of the tissue you will get. From flat gingiva to the beautiful architecture of the gingiva. This is also traumatic extraction case, both the dehiscence as well as soft tissue deficiency case. Place the implants in the proper position, augment the tissues, hard tissue augmentation, then close the implant. During the second stage, go for the soft tissue augmentation. Take the connective tissue from the palate, created a pouch, insert the tissues into the pouch, let it heal for 4 to 6 weeks. You can see the depth as well as the implant placement. Yes, most of the things you saw without any complications, but there are complications for soft tissue harvest. The most common complications is the bleeding. You should know how to handle the bleeding. The second thing is these kind of cases you can expect. See the case when you had come to me, this was like this, completely necrosed tissues. The palate, whatever they attempted. Then we removed all the necrosed part of the tissues, control the bleeding and applied all the anesthetic agents, and this is healing after that. How it was healing. When you had come to me, it was like this, completely healed after that. So that's what everybody tells. You should do the treatment which you can able to maintain or solve the complications. If you are able to handle those complications, do those kind of the procedures or do those kind of the surgeries. So I am not against any cortical implants. Those anybody can do cortical implants. There are sometimes cortical implants very difficult to get the emerging profile as well as the beautiful the soft tissue architect. She is one of the movie heroine, in fact. She came to me, we need to change this architecture of the tissues. In fact, this is a cortical implant, it's joined with the natural tooth. You see how the tissue was then placed. This hard tissue, the soft tissue augmentation now by using the xenograft. That is, see how she had come, how it is now. This is pre-operative, how it was, and this is the post-operative. By just changing the quality of the implant as well as changing the position of the implant and augment the soft tissues. You can enhance the life of the implant now. This is what a lot of work we do on the connective tissue augmentations, that is no matrix. This is a small video about all kind of cases you can practice by using the no matrix. This is what a pre-operative. This is what supplement, what you get it as a xenograft. This is what we got the tissues. The pre-operative, how it was, the post-operative. And we've done a lot of histological evidence also to prove that nothing is left behind that, and whatever the material we placed it is replaced with the natural tissue. Okay, this is to increase the value of the tissues during the second stage. The best part of this tissue is easy to handle. You can stretch it. It will not tear when you placing the suture into that. When you want to stabilize it, it's a very good material to stabilize it. Very good material to handle it. That's mostly, it's almost like a rubber. It's a very good material to adapt it. And you can use a single layer as well as a double layer. If you want to increase a very good thickness, you can make it as a folding also, and you can use that in that way. Fold it, and you can just suture it in that wherever is required. Then close it with these soft tissues, and you will get a good amount of the correct tissue value. Yes, I use it for vertical. All possible soft tissue augmentations you can use it. When you increase the value, increase the horizontal, increase the vertical, whatever things is there, you can use it. But this is only for the connective tissue of the replacement. You cannot use it this one as a free ginger graft. For free ginger graft, you have to go with the Mako graft. This we had done sinus lift procedures, but there was a very thin type of bioduct. To enhance the thin bioduct into the thick bioduct, you can use this material, and you can stabilize that by using healing cap also. That's the beauty of material. Then you can just get the quality of the, enhance the quality of the tissue also. See how beautiful. This is to fill the water. There is a lot of space here, so just to enhance the height of the tissues, just you can create a pouch. You can pull this material into that and increase the thickness of the tissues as well as. There are so many cases like this. I don't want to waste time. Yes, ultimately after the soft tissue augmentations, the most important part is the home care, that is maintenance. After the soft tissue augmentations, if you don't do the maintenance, then end up with again the perimplantitis. So that is by using internal flush, water flush, superflush in some cases, not always, and as well as fluorizing mouthwash. So to conclude, the bone holds the implant definitely, but soft protects the implant. That's most important. The soft tissue management is not an optional at all. It's an essential now. Because we showed a couple of cases how the soft tissue enhance the quality of the life, how soft tissue enhance the survival rate of the implant, how soft tissue help for the aesthetic purpose. It's not only for the aesthetic purpose, it's for the functional purpose also. So soft tissue is an issue in implant dentistry. See, if we have from beginning itself, it's very easy to get the good achievement of the soft tissue maintenance. Thank you so much for giving an opportunity here, and I'm very happy to be here. If you have any questions, any time I'm there, I can clarify anything is there with that, and I have hope. So some the little bit of knowledge I could share about the soft tissue, so that when you plan for the next stage of implants, you'll think about soft tissue in mind and place an implant. Thank you so much. Thank you. That's what the soft tissue story started here itself. That's what I want to tell about it. One patient, I told him about this is a quotation for you to go for implant. About my quotation was around 70,000. He told the same quotation took it and went to another doctor. He did it for 50,000 rupees. There is a problem with the dentist itself. We should never give the quotation to the patient. He'll go to the next 5,000 rupees, I'll make less with this implant. He undergone for the implant. After 6 months, 8 months, that patient came back to me. Say that, doctor, my implant's getting exposed. Then I told, you paid only for the implant, not for the soft tissue. So 15,000 was implant placement. The 20,000 what I added was the soft tissue augmentation, which he didn't do it. He didn't identify it. He didn't do it. So now the implant is getting failed. So now you have to pay for the soft tissue augmentation now. Will you pay it? Yes, means double charge. You'll never be the same charge because it's multiplies. So that's how we have to increase our rates also. See, patient comes for the teeth, not for the implant. That's what I always say, that one thing. Second thing is we have to calculate in our mind that once you place the implant, there is so many things associated with that. If you see those cases, bone graft, membranes, pins, sutures, reservoir sutures you have to put, then soft tissue augmentations, it is costlier than the implant. So managing the peri-implantate is costlier than the placing the implant. So now, in another 5 years, those are periodontists, they are very lucky to say that you can put a special board that a specialist in peri-implantitis management. So many cases are there in the market now to manage the peri-implantitis. So many cases, because everybody is putting implant right and left. Now who will manage? We have to manage. So that's why we have to open a separate branch for the peri-implantitis management branch. So by using the soft tissue augmentation, by using the hard tissue augmentation. That's why I always feel proud to be periodontist, because I can manage the soft tissues. Thank you.
I would not take much more, not more than 5 minutes. It's basically, as a sponsor, it's our responsibility that actually to talk about Colgate products. So in fact, we have a wide range of products. Today I would like to highlight few important products that we have, generally for perio-related. So in fact, sir spoke about perio-related. So we have very core products that is especially for core perio-related issues. So in fact, one is, so basically Colgate PerioGuard. This is something I think most of you are not aware of this brand. So this is something, it's our core brand that we have currently for perio-related issues. I think most of you are aware of this brand, Colgate PerioGuard. So only the misconception is basically you might be thinking this is available in Kirana stores wholesale, but this is not the product for Kirana stores or wholesale product. This is something which we need your support. So support in the sense of recommendation or prescription for your patients. This is something which is available only nearby medical store. Wherever the clinic is, so we will make it available. And hence we need your support for this brand. This is something where we have zinc citrate and sodium chloride. I think this is something. This is the first product that has got zinc content. Zinc acts as an antibacterial agent, and we have a sodium chloride. That is something we have in this 1000 ppm. So this is especially for patients who are having gum-related issues. Generally, how it does, the mode of action is basically it prevents the growth of bacteria, and hence it reduces plaque, and thereby reduces the gum-related issues like gum bleeding, gum irritation. So, and not only that, so many patients who complains about halitosis, this is something really good product. So once you do the scaling, you can recommend PerioGuard as a maintenance scale. That is where the advantage of PerioGuard. So gum-related issues plus halitosis cases, and not only that, once they use this product for their problems, they can continue as a regular toothpaste also, PerioGuard toothpaste. And hence we need your support in terms of prescription, in terms of recommendation for your patients. And apart from that, we do have a mouthwash called Colgate PerioGuard. Same brand name, PerioGuard mouthwash. So you might be thinking, why Colgate PerioGuard mouthwash? Anyway, you have PerioGuard toothpaste. So basically, PerioGuard mouthwash has got a different ingredients. That is chlorhexidine gluconate 0.12 percentage. So 0.1 is basically, it's available only 5% of the mouthwashes in the market. So why 0.1 is basically, it's an optimal solution, no need of dilution. This is something patients, when they go back, they can take it 15 ml and then use it directly without dilution. That is the advantage of optimal solution, 0.12 percentage. So adding to that, we have a low staining formula called sodium tripolyphosphate. That is something, low staining formula that we have in PerioGuard mouthwash. So I think this is the first product in the market which has got a low staining formula plus 0.1 percentage. That is an advantage of Colgate PerioGuard mouthwash. So adding to that, many mouthwashes comes with 100 ml, but we have 250 ml mouthwashes. Why 250 ml is basically, as I said, 15 ml in the morning and 15 ml in the night. Total 30 ml. It lasts for about 1 week. So after 1 week, the patient has to leave it for about 2 days, and then again 1 more week. So any chlorhexidine mouthwashes can be used for about a certain period of time, for 2 weeks. So 2 weeks, again they have to gap of, after 1 week they have to give the gap of 2 days. So that is the reason PerioGuard is placed widely recommended across the globe, not only in India. So we import from Brazil currently and we are marketing in India. So this is the product which we need your support in terms of recommendation and prescription for your patients. So finally we have PerioGuard brush. This is an awesome product. Currently we are selling like a hot cake. So we have 6,000 bristles. This is the first product in the market which has got 6,000 bristles. Not any competitor brands have 6,000 bristles. So this is a premium product. When you recommend patients, they feel, oh, this is an awesome product for your patients. And the best thing is, when you recommend, it should not available in kirana stores or wholesale. Patient might come back and ask you, doctor, anyway it's available in the wholesale and kirana stores, I will buy it. Why would I need your help? This is something where we have placed a rank. This is where we are placed. In the medical stores, nearby medical stores. Apart from that, when you are, some dentists who dispense the products. So we have a customized oral hygiene pack. This is a customized oral hygiene pack. So this is wherein we call Perio Regimen Kit. We have PerioGuard mouthwash, toothpaste and brush, complete kit. So basically the advantage of this kit is the compliance of the patient. So when you recommend toothpaste, toothbrush and mouthwash to a patient, what happens? Patient might not buy all three together. So when you give it post-treatment, generally they buy it all together in your clinic. And do that to lower cost. The MRP of this regimen pack is 625. From the Colgate, we are offering 360 rupees, including printing of the pouch. We print the clinic name, the logo, everything backside. That's a complimentary. We do not charge for it. And the bag also comes along with the kit. The PerioGuard mouthwash, toothpaste and brush all together 360 rupees for the clinic. So this is something we have Perio Regimen pack. And lastly, we have, as Sir said, water flosser. This is something Colgate is again, we have a premium product in the market. And this is available only with our Srihari Enterprises in Davangere. So the best part of water flosser is when you recommend water flosser, any company for that matter. So what happens? They buy it from Amazon. They buy it, and then if something happens, they come back and ask you, doctor, it's not working, it's not getting charged, the water is not coming out. So when you recommend Colgate water flosser, the patients, we will do 1 year replacement for that water flosser generally, warranty. So not warranty in the sense like, if it happens within one year, so the patients can get the new one. The replacement of new brand, new water flosser. So, and also, if in case if you are not dispensing, if in case if you are prescribing, you can give the Mr. Manjunath number also, so that he can give the demo to the patient and he can give the same rate what you are getting in the clinic. So that is the advantage of Colgate water flosser. So hence, these are all our main brand. We need your support for PerioGuard, toothpaste, mouthwash and brush. If in case if you are dispensing, we have a regimen pack also. So we have kept in the regimen packs. You can have a look at the counter. So regarding our Colgate water flosser, we have a special rate that is 3780. MRP is 5,000. Right. So thank you everyone.
For the dinner, let's have a group picture once the cake cutting is celebrated, and then please visit our counter. You will be getting a certificate of attendance plus the goodie bag, and then you can take the bags from the Colgate counter. Now I'd like to invite Dr.